Assalamu alaikum and good evening. And we'd like to thank you to be given this opportunity to be part of your review course. And I hope I will meet your expectations. So the presentation will go through stages. The first stage will be the question, and hopefully this will be guiding you to the theory which we will go through. Okay, we'll go without any delay. So this is the first question, and I want to answer it, or you keep it in your mind and find the answer. And as we go through the lecture, we might have the answer. A 2-month infant referred with the clinical diagnosis of jaundice. The liver function tests are transaminases are elevated, almost 4 to 5 times the normal level, unit per liter, and also the alkali phosphatase and the bilirubin.
The voice is very.
Still again?
Not really. Can you just raise your voice?
Hello?
Yes, your voice is. Can you just raise it a little bit? Thank you.
Oh, okay.
Thank you.
So repeat again. Now you hear it better?
Yes, now is much better. Thank you.
Okay, so I need to raise my voice, charge my voice. Okay. Now, 2-month infant referred with a clinical diagnosis of jaundice, the liver function test, the transaminases, bilirubin, and alkaline phosphatase, and the gamma GT are all elevated. The ultrasound they couldn't comment on the biliary tree because of the gaseous distension. So what is your next step? To do the HIDA scan, repeat the ultrasound, or percutaneous liver biopsy, or proceed for surgical exploration with liver biopsy. Okay, so this is question number 1. Number 2, you have an infant, 1 month old, with a clinical diagnosis of jaundice, liver function test, the transaminases are elevated, the alkaline phosphatase within the normal, the bilirubin is 780 millimole per liter, and the gamma GT within the normal. The ultrasound can visualize the gallbladder. So what is your next step? To do a percutaneous liver biopsy, evaluation for metabolic disease, or proceed for surgical intervention, or to do MRCP. The third clinical scenario, the third clinical scenario is a 5-year-old girl referred with a chronic abdominal pain, and ultrasound showed type 1 choledocal cyst. What is your plan? Do MRCP, do a CT scan, ERCP, or proceed for surgical intervention? So think about it. These are clinical scenarios. Now we come with the knowledge. Does anybody know the two-hit phenomenon is a speculated pathogenesis for which one of the following pathology? Can anybody answer? Okay, we'll leave it for the later once we go through the theory. Babbitt's theory is a speculated pathogenesis for which of the following? Hello?
Yes, there is the answer A in the chat.
The answer is?
The A in the chat, they answered with A.
Yeah, your voice is far away now.
They answered with A in the chat.
Okay. Oh, I see in the chat.
Down below share screen.
Okay, let us go to the theory. Now today we'll be discussing these three pathologies. We'll start with the choledocal cyst and the biliary atresia, going along these content to explore it. In summary, the incidence in biliary atresia is 1 in 10,000, while in the choledocal cyst, 1 in 150,000 for the lip pair. And it is commoner in the Asian region rather than the Western. And the incidence which I told you about is mainly in the Western, while in the Asian area will be even higher, especially in Vietnam and Taiwan. The etiology, if we go to the etiology of the biliary atresia, we can say it is unknown because it is multifactorial. And also the same statement we can say for the choledocal cyst, or are speculation. Some of these theories supported by evidence, and even this evidence, it is not 100% accuracy rate. It's either 80%, 60%. We will go through it when we come to the reading this one. The classification, there is a non-classification for the choledocal cyst, which is the Sudani classification. Also the biliary atresia, there is also a specific classification for it, 3 parts of it, in relation to the anatomy of the extrahepatic biliary system, whether it is a proximal or a distal atresia or fibrosis. They are both in common with the presentation of jaundice, though it is rarer in the choledocal cyst, while it is a cardinal sign or a clinical feature in the biliary atresia. If we go to the diagnosis of the biliary atresia, there is no single test without surgical intervention or interventional procedure, at least, whether it is a percutaneous or surgical intervention to make the diagnosis of biliary atresia. If we want to confirm it, surgery is the answer. While in choledocal cyst, ultrasound is the mainstay of the evaluation radiologically. The laboratory tests all are helping us to define it is obstructive or non-obstructive type of jaundice, but the radiological is the mainstay in the diagnosis of both pathology, especially choledocal cyst. Also, in experienced radiologists, they can make the diagnosis of the biliary atresia by the ultrasound. Now, the management, we have medical part of management, and if it is acute, and the surgical part. In both of them, the surgical part is first in biliary atresia to make the diagnosis, confirm the diagnosis, and go to the, so it is a two-stage procedure. Confirm the diagnosis laparoscopically or by laparotomy, and then proceed to the definitive procedure if the status of the patient allows. And the choledocal cyst, it is a reconstructive procedure. Both of them, they will have a reconstructive procedure, and they are uncommon. Raw and Y hepatic duodenostomy, both of them. Choledocal duodenostomy more in the choledocal. The post-operative care, it is an expected post-operative care in biliary atresia, medical therapy like the antibiotics and the steroid to help the bile drainage. While the choledocal cyst, once you excise the cyst and establish the anastomosis, nothing additional can be added except the regular follow-up. And the outcome for the biliary atresia depends on whether the intervention is early or late. And if it is late, maybe the failure rate of portal enterostomy is high, and then the patient will end with complications related to that and with the liver transplant. While the choledocal cyst has recent or currently most of them are detected early, either antenatal or even early postnatal. The outcome is much better than before. The worry is about the complications related to the type of the procedure we are doing, whether it is a raw and Y hepatic duodenostomy or hepatic duodenostomy. This is in summary what we will be talking about and deliberate as we go. So if we go to the choledocal cyst, it is started in the 17th century, and they describe the anatomy of the choledocal cyst, and as they go, more cases are collected, like by Douglas, he collected a series of 50 cases, and then the classification comes initially by the Alonso Lage. He described the three types of choledocal cyst, and more detailed classification and modification was done by Tudani to make it a 5. It is more predominant in the girls and also more in the Japan, and the presentation is mainly in the first decade of life. More than 60% they will come in the first 15 years of life. And as they present late, the risk of the cumulative risk of the malignancy will be high. And that's why we try, even now, currently, especially in Dr. Lin in Vietnam, they do even in neonatal period, they do the choledocal cyst excision and reconstructive procedure. So as we said, there is no definitive etiological factor that, okay, if we target that etiology, either we eliminate or handle the problem of the choledocal cyst, especially in the like type 5, which is intrahepatic. So there are even more than 16 speculated mechanisms, but the two commonest ones are the inequality of the epithelial proliferation or the pancreato-biliary reflux because of the malunion between the pancreatic duct and the common bile duct. As we said, the presentation is early in life, in the first decade, and the classic triad is not always the case. It's only presenting 25% of the patient. But most of the pediatric, when they present with two of them, either abdominal pain and fever, or abdominal pain and abdominal mass and jaundice, and that is the classical triad. The late presentation is the problem that we are facing. In adults, the worry is about the cumulative risk of cancer. So this is the repetition of what we have been saying in the previous slide. Diagnosing all age group. Repetition is also good to keep the information in our mind and become symptomatic of the test decade of life, and the classified are abdominal and obstructive jaundice and fever and abdominal mass, and it is in this time care activation. So if we initially in the past dealing with the choledocal cyst was just a drainage procedure rather than hello.
ايوه دكتور تفضل.
So did you hear what I have been saying before, or I need to repeat, or it's okay?
No, now it's okay. Even the voice now it's okay. Thank you.
So this is a repetition of what we have been saying. All the worry of leaving behind the choledocal cyst, even if it is symptomatic and discovered incidentally, is the increased risk of malignancy as patients get older. This is the Sudanic classification, the type 1, which is the fusive form and the common form. And then you have the type 2, which is the particular and the common type. And the type 3, when there's what we call a choledoc is within the duodenum. And the type 4, which is intra and extra hepatic. And the type 5, which sometimes we call it the Carolis disease, and it is mainly intrahepatic. This is what we have been speaking about, which is the Babbitt's theory for the choledocal cyst, which is there is a malunion between the pancreatic duct and the common bile duct, and there are three types of this one, depending on the location and the acuity of the joining of the common bile duct to the pancreatic duct. Whether it is at the right angle, or it is a long channel, or it is directly joining to the pancreatic duct with acute angle. As we said before, the laboratory findings are non-specific unless it is late and becoming affecting the liver with recurrent cholangitis. And as we said, if we believe in this theory, the Babbitt's theory, there is also the evidence that it is true. The hyperamylin or the amylase level in the pancreatic duct, which was analyzed in the endoscopic evaluation. So the diagnosis now can be picked up prenatally, and as we said, the ultrasound is actually enough for the diagnosis and even to proceed for the surgical intervention in my view. Further radiological evaluation will just add more anatomical evaluation for the site of the malfunction of the pancreatic duct and the pancreatic duct. But this will not change the plan of surgical intervention. There are also the Japanese, especially Professor Makata, they do intraoperative endoscopy and also intraoperative endoscopy evaluation to the site where they can do the transection of the common hepatic duct in junction with the pancreatic duct to avoid the injury to the pancreatic duct, which can happen sometime and might lead to fistula and also pancreatitis post-operative. So the pathology is a cystic dilatation of common bile duct. In the early stage, it is a normal liver, and because there is a partial obstruction, so there is no lot of pressure into the liver and the spaces, as it happens in the biliary atresia in comparison. As you know, the biliary atresia will try to intervene as early as possible, at least within the first 2 months of life. While the choledocal cyst, they can be asymptomatic, and they can, as we presented before to you, the 5 years old girl who presented to our center with a chronic abdominal pain and then found an incidental ultrasound finding to have choledocal cyst. And the cyst wall is fibrous tissue with absent or ulcerated mucosa. So once we establish the diagnosis, then we just go for the surgical intervention. And the surgical intervention, it is a reconstructive procedure, excising the cyst and doing the hepatico-enterostomy. The type of hepatico-enterostomy, whether you do the raw and wide vaginostomy, which is non-anatomical, but the main aim of it is to establish the drainage and to excise the cyst. While it is, if we are doing the hepatico-duodenostomy, it is more anatomical in the sense that it is in the same, we are not creating the limb, we are not creating additional anastomosis, and it is, this we propose, it is more physiological, and it is easily even accomplished when it is done laparoscopically. This gantrophobic, 20 gram or 80 RCD. So what we do when we go to surgery, of course, we position the patient, depending on the age of the patient, but mostly to the end of the table. The monitor will be on the left side of the patient, on the right side of the patient, to your left as a surgeon, and here will be the anesthesia, and we'll have three boards, really three boards, the camera board, and the two working boards, and then we also use stay stitches to expand or to enhance the view for you. Whether to use it for the gallbladder to retract the liver, to the calciform ligament, and so on. We'll show you the video once we finish this part. So, as we said, laparoscopic hepaticoduodenostomy is technically easier, more physiological, and it avoids the risk of what is happening with hepaticoduodenostomy, raw and wine, and it can be accomplished completely laparoscopically in comparison to the hepaticoduodenostomy, because part of it in some they do it also outside the extractor body intraostomy. The complication, like any procedure that the healing of any tissue that we do suturing is a structure, either this is a long term or immediate anastomotic leak, and most of the time these are the anastomotic leak can be managed conservatively, as most of the time also we use a drain, and it will be controlled with just feeding the patient in parenteral nutrition and antibiotics. These are complications related because when you create whether it is hepaticoduodenoscopy or choledocal duodenoscopy, the risks are there for both the cholangitis and the gastritis because of the bilious reflux into the gastric into the stomach. These are just for history. In the past, we were doing the system colostomy with all the complications which happen. So we are not handling surely the pathology, we are just helping the drainage of the content of the cyst while leaving the pathology behind and the problem which comes with it of the... Okay, this is the laparoscopy for the choledocal cyst budur, the patient which you presented in the 5 years old with with several years of abdominal pain, and in ultrasound found choledocal cyst type 1, which is the common style. Unfortunately, this is unedited video because I lost the one which I edited. I will just run it. So this is what we were speaking about, using the stay stitches to take up the falciform. You see, once you take the falciform up, it will expose for you the area of the operative field that you are working on it, and reduce the number of the boards that you will use for the laparoscopy. So you will have two working boards, one for the, later on will be the needle holder for the anastomosis, and with the, or the hook cautery, and the two forceps. We will move on. Now you can see the cyst. This is the choledocal cyst, which is the diameter on ultrasound. It is 7 centimeter. The good thing about it, it was not inflamed. The area is not inflamed, so it is easily dissected. You can just take the main thing is to stay close to the cyst wall to avoid injury to the surrounding structure. Here will be here is the duodenum, and you continue the dissection as you are doing the hernia surgery. You go around it until you make the inverted V. Once you make it inverted V, you will go behind it, avoiding the injury to the hepatic artery and the hepatic and the portal. And see, there is the common hepatic duct. You see the transition zone. So this is the dilated part of the cyst, and here is the confluence toward the hepatic duct. So we want to reach to that area to do the transection. Here is, you can see that the gallbladder, which is stitched up, retracted. So the view is open for you to continue the dissection. So we move on. So once you have difficulty because the cyst will not give you a chance to hold it, because especially if you are using the 3 millimeter, it is a fine instrument. So we can decompress the cyst. This is a transabdominal needle, or even you can open the cyst wall and put a suction and aspirate the content, and that will ease the process of handling the cyst. Other way also to help you in dissection, once you reach to the posterior wall, you put the vessel loop around and hang it to the anterior abdominal wall to help open, dissecting the distal part of the cyst as you go to where the pancreatic or the joint is with the pancreatic. See, that's the gallbladder, which is stitched to the with a stay stitch. I think here we are inserting the vessel loop maybe to bring it or stitch to stitch the wall of the choledocal cyst to help that. So you will have 2 free hands to complete the dissection distance. So we are, as you go more distally, the cyst wall or it will taper down to the common channel, and then you can do the transection whether you interclip it or transfix. See, these are your left tissue. You can see here the common hepatic duct, and you can see the change in the caliber between the dilated cyst, common bile duct and relatively smaller diameter of the common hepatic duct. See here what we say the inverted V. Once we reach behind the wall of the cyst, we can pass the instrument from this side to the other side, and then you can sling the cyst in order to complete the dissection more distally, and then you transect and go more proximal. Now we're doing the transfixion. You can see the duct which is narrowing down. Now it is a demanding procedure, so you need a lot of this stay stitch to help you to have 2 free hands in order to do the transfixion. Here, this is the duct. You can see it transfixion. So this is the cyst wall and tapering down to the side of the common hepatic duct, and will be close to the pancreatic. As we said, in the Dhaka, they do intraoperative endoscopy in order to see actually the joint with the two. You see the duct now, and you see the pancreatic bed just next to it. Now it is more clear. Now once you transect, you go more proximally toward the common hepatic duct, continue the dissection, lifting it up from the hilar vessels until you reach to the transition zone between the two, between the common bile duct or what we call the choledocal cyst and the side of the common hepatic duct, until you do the transection at that point. So here we are releasing it from the vessels behind the portal vein, and you go more proximally. You come into the content also, you see it is open there. The main thing to be patient and go gently and use the suction irrigation to open the space for you. This is the cystic duct. So we keep the gallbladder all the way to help us in also in contraction. You can see the choledocal cyst at the back. Now we do the transection of the common hepatic duct. Now we're mobilizing the duodenum, vaporizing it. The second part is there. And then again using the stay stitch, you place a stay stitch here so it will be hung up, and then you make the enterotomy, and then you make the anastomosis. Now you see the transection, the common hepatic duct is open, and you can irrigate also the area with saline if there are debris or stones, or even you can do endoscopy to evaluate the intrahepatic ducts since they are dilated. This is the enterotomy for the duodenum, and you can see at the back, you can see the common hepatic duct, how wide it is from the obstruction which has been for 5 years, and the bile is coming down. Now we start the anastomosis with interrupted sutures. You can put the stay stitch also at the same time, hang it back, and then you start with the posterior wall. Once it is completed, you go to the anterior wall, interrupted suture using either the pancreas or to do this, 5 or 4. So the posterior wall is completed. Now the anterior wall. And very important, the location also of the trochus, when you map the location of the trochus before you start the surgery, because it will ease your process of intracorporeal knotting, and so you not you see the angle. It is not acute angle. It is almost like obtuse angle. So the C shape and making the knot is easier life because at least in the beginning, during the procedure, it takes long time, maybe more than 3 hours. But as it's being scaled, your time will be short. So that's completed the procedure. Are you enjoying or you fed up from too many videos? Now is it better؟
The sound, yes, it's better.
لقيتني أحسن أشوف. ممتاز دحين؟
Yes, excellent.
شكله هذا كان بعيد عني. طيب at the end of the procedure, now the anastomosis is completed. You can see it should be tension free, so you have the cauterization of the duodenum, complete the anastomosis, and once you complete, then you put the drain, and that's the end of the story. But before ending the story, you remove the cyst out of the abdominal cavity after you. So we leave the gallbladder to the end of the procedure to maintain to ease the process of the anastomosis as a retractor for you. Now everything is complete. You use the finger of a glove to deliver the specimen out to save the money and to place the drain. So now we go back. Any question for the previous one?
There is a question, but we'll put it at the end of the lecture.
Okay. We go to the second part of the lecture, which is the biliary atresia. As we said in the beginning, the incidence is more in the Asian countries rather than the Western, and also like the biliary system in general, it went through the stages of defining the entity of the disease, and also whether it is a correctable or non-correctable type. It was mentioned before, which is not anymore. Most of it is non-correctable, and the successful surgery was done initially by blood for the correctable type, which is almost like if we can say it is like choledocal cyst, because the distal part is fibrotic, while the proximal part, the common hepatic duct is there. So you do like a choledocal interostom. Though the surgery, if we are doing it for non-surgical or non-obstructive type, it can be harmful to the patient. And the outcome was improving after Mr. Kasai from Japan introduced the hepatic enterostomy, the raw and white. And of course, it will fail all the portal enterostomy procedure, or if the patient is presented late, the liver transplantation disease. This all mentioned in the beginning. Incidence is more in the Asian countries rather than in the European and the Western. And we don't have a single cause for the biliary atresia. There's a good statement that was mentioned in the literature that it is inciting factor in a genetically prepared body, that it will lead to the inflammatory process, and the inciting factor it could be the viruses or inflammatory process of unknown cause which initiate the fibrosis into the biliary system, and it causes the biliary atresia. And there are four or three types, whether it is symptomatic, that's why we say it is congenital, or it is related to infectious, or it can be isolated group of biliary atresia without any inciting pathology. So this is in summary of the etiology. Biliary atresia is a result of an immune response triggered by infectious agent in a genetically susceptible host. So the reason is still unknown, but we are speculating the pathology of the refugees. And this is what we call the two-hit phenomenon. You have inciting factor and a susceptible host genetically. In addition, it is common in some infants or after delivery, in the low birth weight, and why it is uncommon in the preterm. The classification, we have three types, which show you the diagrams later. So So this is the three types, whether it is distal and proximal, and this is the correctable type, which is the rare, while the commonest is the non-correctable type, which was the previous classification. And this is where the advantage of doing the side procedure, when you take the fibrous cord and trace it down to the hepatic plate and dissect it, hoping that the ducts there will be open and do the anastomosis. And then there is subtypes to each of them in relation to the type of the atresia or the fibrosis of the ducts. The diagnosis, as we said, the laboratory diagnosis is just a guide that whether it is obstructive or non-obstructive type of jaundice, but the radiological diagnosis is the most important one, and what we call in biliary atresia the triangular cord. Let me show you. See, this is what we call the triangular cord. Because it is fibrotic, if they define it in the ultrasound, this is very diagnostic of the biliary atresia. So then you go for the procedure type. So this is the study which is done in Thailand. If we have the ultrasound evaluation and it is positive, it's surgery, which is a different procedure. If it is negative, we can proceed for the HIDA scan. And if it is excreting in the intestine or it means that there is no biliary atresia, it is a patency. If no excretion, whether to go for liver biopsy and then will give you the diagnosis, or you go for interventional surgery and laparoscopically with the biopsy at the same time. So as you said, it is very specific and definitive for the diagnosis of biliary atresia. The ultrasound finding of the triangular cord. So basically the problem jaundice, in order to avoid the delay of the diagnosis, laparoscopically, if the gallbladder is present, then we do laparoscopy cholangiogram, of course. If we demonstrate the passage proximally and distally, then we will just finish with liver biopsy. If there's no contrast passing proximally and distally, it means there is extrahepatic or biliary atresia, and this is to proceed for the definitive procedure. So this is the intraoperative cholangiogram. We use a spinal needle, go to the gallbladder if you find it and inject, and this is the demonstration that it is atresia. So the success for the port enterostomy or the definitive procedure depends on the timing, and the timing is not only determining factor, it's also the status of the liver. Because if it is aggressive inflammatory reaction, it can be also early cirrhosis with advanced stage of fibrosis, like stage 4 of pathology. And in that case, maybe better to go for liver transplant if it is available in the center. Otherwise, can give the chance of the port enterostomy, and with the failure rate would be higher if there is a profound fibrosis or affection of the liver. The post-operative care, we continue the antibiotic and also the steroid. The steroid to reduce the inflammation and also to enhance the bile flow. So this is the effect of the steroid, two principal ways to limit the inflammatory process and enhance the bile flow from the liver. And there are several protocols with the complication related to the port enterostomy if it is the success that there's a bile flow. But on the other hand, cholangitis can happen from the reflux, and this will adversely affect the liver function and might accelerate the liver failure, and then the patient will end with the need for the liver transplantation. Can we perform the procedure in after 3 months? The answer is yes and no. Yes, if it is in selected cases, no, if it is the patient is already advanced and will be the need for the liver transplantation. Just give me a few seconds, please, just to operate this. No?
Okay, take your time.
Okay, this is the laparoscopy for a patient, jaundice patient, the one which we present in the question. You can see the liver. It is present and it is green in color. And it is what you see now is the gallbladder. So when we see that gallbladder is unlikely to be biliary atresia. So another way to confirm that we can put a needle through the gallbladder and aspirate the content which was bile, and you can see the biliary tree. If you can appreciate, you can appreciate the ducts. Okay, here is the needle aspirating the content. I'm not showing you outside the ceiling is with bile. Unfortunately, I cannot open for you the other one which will show you the biliary trees. Again, the same principle for the choledocal cyst. We also on the biliary atresia, the same both sides. If we are doing the exploration for the cast side, uh, for my personal experience, I'm not doing it. I will just dissect the blade up to the porta hepatis and then complete the procedure by the open technique. It is more demanding in the biliary atresia because of the fibrotic liver and also the retraction to make to reach to the area of the portal blade. So the three essential techniques in order to achieve functional bile-enteric anastomosis, you have to identify the cord and follow it up to the bifurcation proximal to the portal vein. And also there is additional technique which are described to take down the ductus venosus, and that will expose more the blade in order to have a wide area for the anastomosis. In some centers, they do also the plate simply for a frozen section to see if the ducts are patent, and hoping that it will improve the status for the post-operative. And you expect things to happen within the first 2 to 6 weeks, that the bile or the bilirubin will drop down if it is functional, and the liver regain its secretion. In the past, also, it was prescribed to have to reduce the chance of cholangitis, do externalization of the proximal limb as a stoma, and do irrigation. And later on, once the cholangitis frequency reduced, because the frequency of cholangitis happened in the first 1 to 2 years of life after the cycle. This we spoke about that post-operative the patient should continue for prophylactic antibiotics and also the steroid therapy, and the protocols are different from one center to the other. As we said before, the age is important, but also the status of the liver or the aggressiveness of the disease to patient is another factor for the surgical intervention. We have to proceed with the bottom colostomy, which can help the patient for several years or the first decade of life. And most of them they will end by doing the liver transplantation. Or you cannot do it at all, and you do the liver transplantation from the beginning in the center, like in King Faisal it is available. So if you make the trend now actually in King Faisal is to do liver transplantation if we have the evaluation, the intraoperative evaluation that it is already affecting the liver adversely or in the advanced stage. Now, in the other areas, in order to catch these patients in centers like in Asia or in Taiwan, they did a screening for the neonates for the to catch the patient early for the biliary atresia or at least for evaluating them. The other thing also adopted is to centralize doing the procedure because the outcome will be better if you have the bulk procedure done in one center or two centers. Because, for example, if you are doing less than 5 cases per year, the outcome, according to the study, is less in comparison to centers where they have a higher volume. Because the experience will be more, the protocols will be more standardized, and of course, logically, the outcome will be good. Okay, that's what I want to talk about both, but also what is lacking in our country is the information about the choledocal system the biliary atresia. I searched for you, and there are several articles, 5 of them, which are reported mainly from the Eastern Province and the Western Province. Uh, about it is a case report about choledocal cyst and biliary stone, and there's choledocal cyst, 2 case reports by Dr. Ahmed Salim, and also the outcome. And this is a tertiary center from here from Riyadh. This is from Fahd Medical City, and also the other one from Dr. Jamal from Egypt. And the conclusion of all of them is having matching the international things, but still another thing we are lagging behind is the late referral of the patient, especially with those with the neonatal jaundice. They come in an advanced stage, and the intervention, the outcome for them is below the expectation. Sure.
Thank you, Dr. Zakaria, for your nice presentation despite the technical issues that we faced. We have some questions. Dr. Arash is asking, what is the risk of malignancy in choledocal cyst?
20 to 30%, that's it can go up to 30%.
Okay. And opening of the choledocal cyst, is it mandatory or just preferred? And what is the timing of opening it, early on dissection or late just before releasing the posterior wall?
I think 2 things. The size of the cyst will determine for you. For example, the one which I show you, it is 7 centimeters. And if you are using a small instrument like the 3.5, it is delicate in comparison to the heaviness of the cyst. So to ease the process, you can do it initially, either aspirate or even open it and suction the content. And that will ease the process for you to go for especially behind it in order to avoid the vascular injury. So it depends on your easiness of doing the procedure for you. But I think at the end you will need it to be decompressed, whether by the needle or by the suction.
Okay, thank you, super. And the last question is, if the liver biopsy showed grade 3 to 4 liver cirrhosis, still we go for Kazai procedure?
Depends on your center. If you don't have the liver transplant, the answer is yes. If you have a liver transplant like what we have, we just leave it for them to take over. And this is actually happening now for the last, I don't remember, we are doing this side for the last 3-4 years.
Okay, this is the question that we got. Thank you, Dr. Zakaria. We are very happy that you joined us and shared your experience in our review course. Nice and excellent presentation despite the technical issues. Thank you so much. See you soon, inshallah. Thank you, Dr. Zakaria.